Hi, I'm Staci Kallish. I'm a medical geneticist and the Associate Professor of Clinical Medicine at Penn Medicine and the Children's Hospital of Philadelphia. We're going to talk today about Fabry disease and some research highlights from the WORLDSymposium from 2023. I take care of a large number of patients with Fabry disease in the lysosomal storage disease clinic at Penn Medicine. Here are my disclosures. So the WORLDSymposium is an international research symposium focused on lysosomal storage diseases. In 2023, the meeting was held in February in Orlando, Florida, and all of the abstracts from the meeting are available and were published in Molecular Genetics and Metabolism. We'll start by talking just briefly about Fabry disease. So Fabry disease is a rare, heterogeneous, X-linked lysosomal storage disorder. It's caused by variants in the gene GLA, which leads to a deficiency of an enzyme alpha-galactosidase A, or AGAL-A. The reduction or deficiency of AGAL-A leads to accumulation of glycosphingolipids, specifically GB3 and related analogs, in cells and in organs, and this leads to multisystem organ disease and organ failure. Current standard of care involves enzyme replacement therapy given by IV or chaperone therapy, which is oral. There are a number of additional treatments currently under investigation, and some of these were presented at the World Meeting, and we'll talk about them today. Here's what we're going to talk about today. So we'll talk first about some new clinical data from currently approved therapies. We'll then talk about data from some investigational therapies. We'll review a little bit of data specific to cardiac manifestations, and then review some additional data from current real-world populations of patients with Fabry disease. Okay, so jumping in with the new data from currently approved therapies. This first presentation looks at safety and tolerability of shorter infusions for Fabry disease. Agalsidase beta is an FDA-approved ERT for Fabry disease, currently dosed biweekly at 1 milligram per kilogram body weight, with increasing infusion rates based on tolerability. In the US, the label specifies for infusions over 90 minutes for patients who are over 30 kilograms. In the US and in the EU, the label states for patients under 30 kilograms, infusion rate should be less than or equal to 15 milligrams per hour. But in Japan, the label allows for infusions up to 30 milligrams per hour, which allows for infusions under 90 minutes for those up to 45 kilograms. This study looked at post-marketing data in the Japanese population and analyzed infusion-associated reactions, adverse events, and serious adverse events based on infusion rates and patient attributes. Data were available from more than 2,800 infusions over 90 minutes, and from 473 infusions that were under 90 minutes. Overall, the SAEs were rare and similar in both groups. Among patients of all weights, in the top part of this table, you can see that infusion time did not impact IAR rates or SAE rates, and that AEs were actually more common in those with infusions over 90 minutes than in those under 90 minutes. In the middle, you can see that smaller patients were not at higher risk, and that AE rates and SAE rates were similar for both groups. For patients under 30 kilograms, specifically, faster infusion rates, so those with infusions over 15 milligrams per hour versus those with infusions under 15 milligrams per hour, those with the faster infusions actually had lower rates of IARs at 1.7%. versus 7% rates in those with slower infusions. There were no SAEs reported in this group. Similar trends were seen when looking specifically at patients under 45 kilograms. The rates of IARs, AEs, and SAEs did not differ significantly among patients with or without positive anti-drug antibodies. These findings suggest that patients who are tolerating treatments can, with careful monitoring, gradually decrease their infusion times. Next, we'll look at patient perceived time to improvement and changes in symptoms while receiving ERT. This was an observational, cross-sectional, web-based survey that was conducted in the U.S. to characterize pain in patients who have Fabry disease and experience either moderate or severe neuropathic pain or abdominal pain. The analysis focused here on the subset of patients who were receiving agalsidase beta. There were 45 patients included, 21 of whom were male, with a mean age of 44.6. Participants were recruited from the Fabry Support and Information Group, or FSIG, and answered questions based on their symptom changes and treatment satisfaction. Most participants reported classic Fabry disease. Almost half of the patients reported severe neuropathic pain, and more than 40% reported moderate abdominal pain. Most participants, more than 80%, reported improvement in their symptoms with agalsidase beta. Among the 37 participants who reported improvement, the most frequently improved symptoms were burning in the upper extremities, pain in the upper extremities, burning in the lower extremities, sweating, and abdominal pain, and these were all reported to be improved in between 35 to 45% of patients. Looking at those who reported improvement, only 13% reported improvement in their first 2 months of treatment. An additional 31% reported improvement between 2 to 5 months, and another 20% between 6 months and a year. Still, 17% of patients reported that their improvements did not begin until after 12 months of treatment. Participants who were treated reported a mean satisfaction score of 7.2 on a scale of 0 to 10, with 10 being completely satisfied. In summary, most patients perceived improvement in a number of their Fabry disease symptoms, with the majority of improvements occurring after 2 months of treatment. This is data from the Follow Me Fabry Pathfinders Registry. This is a registry that's designed to evaluate clinical safety, effectiveness, and patient-reported outcomes for patients who are receiving current treatments for Fabry disease. The registry enrolls patients at least 12 years of age, with an estimated glomerular filtration rate, or eGFR, of at least 30, and patients are divided into 3 groups: those with migalastat amenable variants who are receiving migalastat, those with any GLA variant who are receiving enzyme replacement therapy, and those with migalastat amenable variants who are not receiving any Fabry-specific therapy, which is an untreated or natural history group. A total of 427 patients have enrolled in the registry. Looking specifically at female patients, 229 females have enrolled. You can see their treatment status here. Overall, females comprised 40% of the migalastat arm, 55% of the ERT arm, and 78% of the untreated arm. And 42% of females overall were untreated. At enrollment, their baseline characteristics are listed here. You can see for the mean eGFR, the mean eGFR was 87.2 in the migalastat group, 92.4 in the ERT group, and 100.4 in the untreated group. In total, 6.6% of the females had a mean eGFR less than 60, and for each group that was 12.6% in the migalastat group, 6.4% in the ERT group, and 1.1% in the untreated group. The median LVMI, or left ventricular mass indices, are listed here as well. Looking at these untreated females and their symptoms and comparing them to untreated males in the group, you can see that the females have many symptoms, including GI symptoms, acroparesthesias, corneal verticillata, angiokeratomas, and hypohidrosis. And the age of onset for GI symptoms and acroparesthesias was younger in untreated females compared to the untreated males. And so, despite the untreated females exhibiting similar prevalence of classic symptoms and potentially at younger ages compared to the untreated males, they were less likely to be treated. And this suggests that females with Fabry disease should be closely monitored to assess their disease progression. Also from the Follow Me Fabry Pathfinders Registry, this looks at clinical follow-up of patients who received at least 3 years of migalastat treatment. As of August 2022, 125 patients, 60% of whom were male, had a mean total megalostat exposure of 3.9 years, and 116 patients received a mean of at least 1 year megalostat exposure prior to enrollment. You can see their baseline characteristics here. At enrollment, the median LVMI was 15.1, 131.2 in males and 98 in females. So the median albumin creatinine ratio was 17.9, 11.4 in males and 33.3 in females. And the mean eGFR was 83.7 in the group overall and similar in both males and females. Overall, 36.8% of patients had an eGFR above 90, 47.2% had an eGFR between 60 and 90, 12.8% had an eGFR between 30 and 60, and only one patient had an eGFR below 30 at enrollment. Looking at the overall population, the median annualized rate of change in eGFR from enrollment was minus 1.2. For males, this was 1.4, and for females, this was 1.1. These data are consistent with the long-term renal data presented by Pichet et al. In 2021 and support long-term megalostat use in patients with amenable mutations. Next, we'll talk about some data from investigational treatments that are currently ongoing. Current therapies that we've already discussed include ERT and chaperone therapy. But these are limited and require repeated administrations, which can impact patient safety and quality of life. And there remains an unmet need for durable therapies that have a single administration. This study looks at ST920, which is an investigational gene therapy that uses a recombinant AAV2/6 vector that contains a human GLA cDNA, which is administered by a single IV infusion without prophylactic steroid treatments. The study is called STAR, and this is an ongoing phase 1-2 multi-center open-label dose-ranging trial that is a dose escalation and dose expansion phases that evaluates the safety, tolerability, and efficacy of ST920 in patients with Fabry disease over 18 years of age. There will also be a 4-year long-term follow-up following the initial 52-week evaluation period. As of July 21st, 2022, 9 male subjects with classic Fabry disease and a mean age of 39.7 have been dosed in the dose escalation phase with 4 ascending cohorts, and they've been followed for up to 23 months. All produced supraphysiologic alpha-Gal A activity, and this ranged from 1.9 to 30.4-fold normal at their time of last evaluation. 4 of these subjects were able to discontinue their ERT and maintain above normal enzyme levels up to 28 weeks post-ERT withdrawal. Lyso-Gb3 levels were measured and declined in subjects with the highest baseline levels. There were no serious treatment-related AEs, and all treatment-related AEs were considered mild, except for 1 moderate AE of pyrexia. Based on these data, the dose expansion phase of the study has been initiated, and ST920 continues to be well tolerated with sustained supraphysiologic enzyme activity in plasma maintained after ERT withdrawal. The next study looks at peg-unigalsidase alpha, or PEG-alpha, and compares it to agalsidase beta. PEG-alpha is a novel pegylated agal-A ERT that's in development and designed to offer potential convenience and tolerability benefits, as it can be dosed every 4 weeks instead of every 2 weeks. The BALANCE trial assessed the non-inferiority of PEG-alpha compared to standard of care agalsidase beta in adults who were previously treated with agalsidase beta for at least 1 year and had an eGFR slope of at least or more negative than -2. Patients were randomized 2-to-1 to receive 1 milligram per kilogram of PEG-alpha or to remain on their agalsidase beta dose every 2 weeks for 2 years. The primary efficacy analysis assessed non-inferiority based on mean annualized eGFR and the difference between the two groups. A total of 77 patients were enrolled, 52 receiving PEG alpha and 25 receiving agalsidase beta. At baseline, the mean age was 44 with a range of 18 to 60. 61% of the patients were male, and the median eGFR in the group was 74.51 with a median eGFR slope of minus 7.25. After 2 years, the difference in median eGFR slope between the two groups was minus 0.36, which met the non-inferiority margin. Secondary endpoints included LVMI, pre-medication use for infusions, the brief pain inventory score, and lyso-Gb3 levels, and these indicated stability and were similar between the two groups. Safety analysis showed infusion-related reactions favored PEG alpha, with 21% of patients receiving PEG alpha reporting a total of 13 IRRs for 0.5 events per 100 infusions, compared to 24% of patients receiving agal beta reporting a total of 51 IRRs for 4 events per 100 infusions. Treatment emergent AEs were similar, with fewer events in the PEG alpha group. Of patients who had a positive anti-drug antibody status at baseline, the percentage of patients with neutralizing antibodies declined in the PEG alpha group from 94% to 64%, but increased in those receiving agalsidase beta from 88% to 100%. There were no deaths in the study in either arm. PEG alpha showed non-inferiority in terms of efficacy compared to agalsidase beta based on the eGFR decline over 2 years, and had better tolerability and immunogenicity with lower rates of treatment emergent AEs. This next study looked at pre-existing anti-drug antibodies, or ADAs, in those who were receiving ERT. We know that male patients with classic Fabry disease without cross-reactive immunologic material are at the highest risk for forming neutralizing antibodies and anti-drug antibodies against ERTs. And this can significantly impact the therapeutic efficacy. The aim of this investigation was to analyze the cross-reactivity of these anti-drug activities against currently available ERTs against PEG alpha, which is the experimental ERT that we just discussed. When studied, the affinity of purified anti-drug antibodies from pooled patient sera from 49 patients was significantly lower for PEG alpha when compared to either agalsidase alpha or agalsidase beta. Pull-down experiments then revealed that the presence of masked epitopes on PEG alpha might be due to pegylation, might be the reason for this. Then the anti-drug antibody titers in serum and their inhibitory capacities against agalsidase alpha and beta were measured in these patients and showed strong correlations. The affinities of these ADAs against PEG alpha were lower when compared to agalsidase alpha or beta. Cross-ELISA studies were then completed, and these supported the presence of masked epitopes on PEG alpha. Importantly, inhibition measurements revealed a 30% reduction in inhibitory capacity of these pre-existing ADAs towards PEG alpha. And then finally, enzyme uptake experiments in agal-deficient cells demonstrated that there were less effects of these ADAs against cellular uptake of PEG alpha compared to uptake of agalsidase beta. This suggests that for patients with pre-existing ADAs, they might benefit from therapy switch to PEG alpha. Finally, we'll discuss one additional experimental therapy called 4D310, which is an investigational genetic medicine for Fabry disease that is a unique dual mechanism of action that addresses high unmet need in the heart and the kidney glomeruli that may persist in patients receiving ERT. 4D310 employs a targeted and evolved AAV vector called C102 that delivers a codon-optimized human GLA transgene directly to cardiomyocytes and kidney glomeruli. This includes the podocytes, with the hope of cell-autonomous agal-A production after IV administration. In addition, the efficacy may be augmented by cross-correction from enzyme that's secreted into the blood. This is the phase 1/2 trial that evaluates a single IV dose of 4D-310 in males and females with classic or late-onset Fabry disease. The cardiac endpoints in the study are assessed by a masked central reading center and include peak VO2, which is measured by cardiopulmonary exercise testing, the Kansas City Cardiomyopathy Questionnaire scores, or KCCQ scores, global longitudinal strain by echocardiogram, and cardiac MRI. Cardiac data are available for the first 3 patients who were dosed and reached 12 months of follow-up. All 3 patients had baseline anti-AGA antibody titers that range between 1 in 1,000 and 1 in 100,000. 2 patients were receiving ERT when they entered the study. Both were able to discontinue their ERT treatment at 2 and 14 weeks after dosing. There was no cardiac toxicity observed in the study, and this was based on blood biomarkers, echocardiogram, and EKG. At week 52, peak VO2 increased in the 2 patients with week 52 data available. The 3rd patient is still pending. KCCQ scores increased in the 2 patients whose scores were below normal at baseline. The score for the 3rd patient remained in the normal range. GLS and cardiac MRI improved in the 2 patients with week 52 data. Again, the 3rd patient remains pending, and in contrast to worsening scores seen over a 1-year period in patients in the literature. No patient reported a worsening of any of their cardiac endpoints during the period of observation, and so 4D-310 seems to show promise as a genetic medicine for Fabry-related cardiac disease. And then finally, we'll look at a number of studies that reported data from real-world cohorts of patients with Fabry disease. The aim of this study is to determine the natural history of Fabry disease in early pediatric patients with classic variants of Fabry disease and to evaluate possible correlation with lyso-Gb3 levels. We think that the classic variant of Fabry disease usually presents in the first decade of life in almost all boys and in most girls. As of now, though, there are a few studies correlating clinical manifestations and the values of lyso-Gb3 in children under 3 years of age. The children who were included in this study were diagnosed due to a known family history. Their parents were trained to recognize early manifestations of Fabry disease, and none were receiving ERT. There were 5 children enrolled in the study who were all male. The mean age of first symptom for these patients was 21 months, with a range of 12 to 36 months. And the most common manifestations were abdominal pain and diarrhea, followed by heat intolerance and pain in the hands and feet. When measured, A-gal-A enzyme was severely reduced or absent in all patients, and lyso-Gb3 levels were at the upper limit of normal. There was a correlation seen with lyso-Gb3 levels, with the highest levels of lyso-Gb3 in those who had earliest onset of symptoms. In one patient specifically, lyso-Gb3 was measured over time and shown to progressively increase. This suggests that the onset of clinical manifestations before the age of 3 in patients with classic Fabry disease is more common than previously recognized, and that clinical and biomarker correlations support lyso-Gb3's use as an early criterion for treatment consideration. In addition, lyso-Gb3 may be used to suggest therapy even before the onset of symptoms, as some international guidelines now suggest. This study assessed the performance of a machine learning platform to estimate patients' 12-month stroke risk. Stroke is known to be a major driver of morbidity in patients with Fabry disease, but due to disease heterogeneity, risk varies substantially. Identifying stroke risk in patients with Fabry disease could significantly reduce morbidity and mortality. Machine learning models have been demonstrated to show strong performance in stratifying patients with by outcome risks. In this study, data was drawn from a de-identified US-only claims and electronic health record dataset that covered January 2013 to July 2021. A total cohort of more than 5,900 patients with Fabry disease was identified using diagnosis codes. Within this cohort, 509 patients were identified who had stroke. 203 of these had their first stroke after their diagnosis with Fabry disease. A general non-Fabry disease cohort was also constructed using 500,000 patients with prior stroke and 500,000 patients without stroke. The platform used these groups to estimate stroke risk within a 12-month period of time following randomly selected index dates, and these were varied to test stability. The performance was then evaluated on a holdout set of records that were not included in the initial data set. The platform was able to achieve strong performance in estimating the 12-month stroke risk in patients with Fabry disease, with an area under the curve of 0.77, which is a good AUC. Key signals driving the performance were compared between patients with Fabry disease and those without Fabry disease, with a roughly 70% overlap between the two groups. Signals indicating higher risk in the Fabry cohort highlighted cardiac and vascular anomalies, prior cardiac testing, and more advanced Fabry disease. In the non-Fabry cohort, cardiac health indicators were more prominent, as were features including advanced age. The machine learning platform was able to achieve strong performance in estimating stroke risk in Fabry disease using a range of features. This supports potential application to improve Fabry patient management by highlighting those at greatest risk. Similar work is ongoing to assess risk of arrhythmias in patients with Fabry disease as well. And finally, we know that monitoring and treatment adherence in patients with Fabry disease may be influenced by their subjective beliefs about their illness. The last slide here shows data from two studies that explore patient perspectives, first looking at patient-reported connections between monitoring practices, treatment, and disease burden. This was conducted by IRB-approved double-blind cross-sectional online survey of adults with Fabry disease in the US and in Canada. There were 280 respondents, 208 currently receiving ERT, 26 receiving migalastat therapy, 9 who had previously received ERT but were currently untreated, and 28 who had never been treated. When asked about disease worsening, 86% of patients who were treated and 54% of treatment-naive patients and all patients who had discontinued their ERT perceived that their disease had worsened despite stable lab values. Of patients who had received or were currently receiving ERT at the time of the survey, 42% were unsure if they had ever been tested for anti-drug antibodies, and those who had been tested or reported being tested for ADAs, 31% were unsure of the results. More than half of the patients who had ever received ERT experienced temporary symptom worsening between infusions, but only half of these patients reported speaking to their care teams about their symptoms. This indicates that for patients with Fabry disease, they often perceive that their disease symptoms as burdensome and of progressing, irrespective of treatment status and stable lab values. Healthcare providers could initiate more discussion with patients around their illness beliefs and their symptoms, and this may help them provide better education and discussion about the connection between disease monitoring results and disease progression. And in the second piece on patient perspectives, an AI analytics engine was used to identify the prevalent concepts in social media data using natural language processing. This was applied to an online community of patients and caregivers discussing their experiences with Fabry disease, specifically using a private Facebook group, Fabry Disease Info and Support, which contained more than 96,000 posts or comments from 2007 to 2021. The platform identified posts and comments that discussed mental health, identifying more than 9,000 poster comments, or 9.4% of the total comments. The most frequent mental health outcomes that were identified included discussions of stress, anxiety, and depression. The platform then extracted the 10 most frequent symptoms from the dataset and used logistic regression models to determine which symptom mentions then predicted mental health outcome mentions. Pain was a significant predictor in all three models, with an adjusted odds ratio between 2.3 to 3.3, which suggests that posts or comments mentioning pain were 2 to 3 times more likely to also mention a mental health outcome. These results demonstrate a significant relationship between physical symptoms of disease and negative mental health outcomes. Future work might further explore these relationships so that clinicians, caregivers, and patients are better identified and can better understand and manage mental health concerns in the context of chronic disease. So in summary, today we discussed new data that was presented at the 2023 WORLDSymposium and discussed that patients who are receiving ERT may be able to gradually decrease their infusion time, that immune responses to agalsidase beta have limited impact on therapeutic effects, that females with Fabry disease exhibit similar prevalence and severity of symptoms to males, but are less likely to be treated for their disease. Treatments that are currently under development, including ST920, PEG-alpha, and 4D310, show promising efficacy and tolerability. GI, neurologic, and sweating concerns are common in female patients with Fabry disease. Symptom onset in children under 3 years of age with classic Fabry disease may be more common than is previously recognized. And AI and machine learning tools show promise in recognizing undiagnosed patients with Fabry disease and in risk assessment for these patients. Thank you.